Good afternoon, everyone. Thank you very much for joining us in this webinar in partnership with the Fellowship of Postgraduate Medicine. My name is Dwayne Schultes. I'm the Managing Director of Vital Transformation. We're assisting with this webinar. Today, we'll be discussing equity and outcomes, ensuring fair access to healthcare. Thank you very much for joining us. We will be taking your questions. We have an excellent panel. We are certain that you will like to ask them your questions. To do so, please use the Q&A button in your little menu. That's the little Q&A menu item there. Press that button, the menu pop up and you can submit your questions. If you're having difficulty with your audio, we have provided two dozen different toll-free phone numbers. You can quickly switch in the menu here in your mute button. There's a little arrow. You can pull up this menu and switch the audio if you're having issues with your connectivity, and you can easily dial in because we absolutely want your participation. With that, I now pass over to Donald Singer, the President of the Fellowship of Postgraduate Medicine. Donald, the floor is yours. Thank you.
Dwayne, thank you. I'm delighted to welcome you all to today's session. This is the third in a conference series to mark the 10th anniversary of the Journal Health Policy and Technology, which is owned by the medical society I chair, the Fellowship of Postgraduate Medicine, which is UK-based but international. Today's session is on equity and outcomes, ensuring fair access to healthcare. And we've got a very strong international panel with two speakers from Scandinavia, one from UK and one from North Africa, from Morocco. Without more ado, I'm delighted to introduce our first speaker, Professor Olli Ottosson, who is president of the Karolinska Institute. He's a distinguished clinician academic, previously rector of the University of Oslo. He chaired the Lancet Global Health Commission. He himself is a distinguished neuroscientist. And I'm delighted to ask Professor Ottosson to give his perspectives on current global health challenges to improving healthy life expectancy.
So first of all, thank you for inviting me to this exciting meeting on a topic that is perhaps one of the most important topics that we can possibly discuss today, and particularly after COVID-19 has unveiled some of these inequities that we knew were there, but they have been accentuated, I would say exacerbated, magnified through the current pandemic. So it's a very important discussion that we're going to have, and I will try my best to put in some perspectives from Karolinska Institute, a medical university that has been very much engaged in this pandemic, obviously. And Donald, we met, in fact, in Stockholm a few years ago, and I guess the topic was more or less the same as the topic that we are addressing today. So the issue is, in fact, how we should deal with gaps and needs in the provision of global health. And I will introduce a new concept that has matured in my own institution after the pandemic hit. And we have labeled this new term sustainable health, which has to do with much of what we are discussing here today, how we can ensure that healthcare is sustainable, that we can provide healthcare also for future generations without the inequities that we are facing today. And it is correct that, let's say here, it moves slowly, that I was chairing a commission, in fact, a few years ago on equities in health. And the backdrop was, what are the root origins of health inequity? The causes behind the causes, so to speak, behind the social causes of health inequity. And we soon realized that many of the root causes, they are to be found, of course, in policies, in politics. So we addressed what we can call the political and commercial determinants of health. There is no way that I can go into the conclusions of this commission, but I guess that some of these conclusions are well known. And of course, one of the tragic features that we uncovered in this commission was that too often in the governance system, health is subordinated to economic goals. That's a sort of a common denominator, I think, for many of the health inequities that we see today. Also, we had a lot of emphasis on trade agreements, how in fact trade agreements contribute to the inequities that we are going to discuss today. And on the backdrop for this particular meeting, you refer to life expectancy and differences in life expectancy, and you say that even within or among countries with more or less the same GDPs, there is a tremendous difference in life expectancy. In fact, when I looked at the data now, within lower and middle income countries, there is even in this range 20 years difference when it comes to life expectancy. And of course, this is utterly unsustainable. And you can see here the color code varies quite a lot, with of course Africa being in a very, very difficult position. And what do we see now? I will come back to that later. The inequities are highlighted, of course, with the vaccine distribution. And in this particular paper in Nature, this figure comes up, and we have discussed this figure ourselves in many different papers, that only 1% of the vaccines administered in Africa are produced in Africa. And of course, this is utterly unsustainable. And I must say that it's almost painful to realize that we are still struggling with this technology divide. And this technology divide has not improved on what is in fact our watch. So there is a tremendous and urgent need for improvement. Of course, the Sustainable Development Goals, they motivate, and they really show very well where are the inequities, and also they point to solutions. And there has been a debate, as you know, in the literature, whether we should simply forget about the Sustainable Development Goals after what has happened now in this crisis, or should we revise the Sustainable Development Goals? I think they are still relevant, even more relevant now than they were before the pandemic hit. But of course, this is an international debate that I guess that many of you have contributed to. And when it comes to COVID-19 vaccines, again, I think that when we look at the inequities, we have to address governance mechanisms, the political determinants of health. And it's quite clear to me that the entire global governance system has to be revamped in order to tackle the challenges that we see today. It was the global governance system was, of course, very much created after the Second World War, where the profile of challenges differed completely from what we see today. So how this shall be lifted, this problem shall be lifted in the years to come, that remains to be seen. But in this paper in Nature Medicine, we argue strongly, I guess, for revamping of much of what now must be seen as a global governance system that is outdated. Of course, the WHO has to play a role also in the time to come, but I think that academia, that's of course reflects my background, academia should take much more responsibility, I think, when it comes to addressing the inequities that we're discussing today. So at the Karolinska Institute, we have a new strategy with its same time horizon as Agenda 2030. And in fact, the mission and the vision is to strive for a better health for all. And I think this is should be the responsibility for all medical universities, of course, to really highlight what is the meaning of all in this context. Of course, it means that we shall cater to health across borders, geographical borders, across socioeconomic strata, but also across generational borders, sustainability. And that's why we have introduced now this term sustainable health, which I think introduces the time dimension that is so important in everything we do now. We should not only look at how we distribute vaccines, for example, today, but how we tomorrow can have vaccine production facilities more evenly spread across the globe. So the time dimension in health is really important. And I think it's often forgotten. We have to think with a long-term perspective to improve things. So this is the definition that we're using for sustainable health. Of course, it embodies a commitment to future generations. It says that we should stay within planetary boundaries, of course, when we develop the healthcare system for tomorrow. And it's all based on the Brundtland Commission that goes back to the 1980s. I guess you all remember this commission as being quite important in introducing the term sustainability, in fact. So sustainable health, what is sustainable health? Well, it's quite clear that COVID-19 has highlighted what must be the most important aspects of sustainable health, the interdependence between health and the myriad of socioeconomic and political factors, and also how we have to look at these inequities now with much more effort and energy than we did before the pandemic hit. So these are some of the aspects of sustainable health. I mentioned already, we should not compromise the health of future generations. We should have an accountability also for the health of future generations. Community engagement is important. We have to think across sectors, and we should go beyond research and see implementation as the final goal. I think we have to be self-critical when it comes to international collaborations in global health. Very often we have this sort of hit and run strategy. We are doing a research project in a different country and then we write a report and that's it. We must have a much longer time perspective and see implementation of new knowledge as the final goal. And we have in fact just last week launched a Center of Excellence for Sustainable Health with Makerere University in Uganda, based on exactly the principles that I just discussed with you now. And the central is in fact to have long-term projects that hopefully end up in new policies and better healthcare. But it's a challenge. We have to look at and revise the entire structure as it of international collaborations within global health. Self-criticism is in place. We have termed, again, to get the time perspective into health properly, we have coined also the term universal preparedness for health as an important term. Universal preparedness means that we should not only think across, again, geographical boundaries, across generational boundaries, but also ensure that preparedness applies across socioeconomic strata. So that's why we introduced the term universal here. So what are we, I mentioned this technology divide that contributes to the inequities that we are discussing today, not least when it comes to the production of medicines and vaccines. I think this is a sort of symbol and a very sad symbol of the technological divide that is contributing to health inequities today. So we are trying now our best also, in fact, to go into concrete projects with different countries in Africa to see how we can ensure an academic push towards vaccine production capacity. Of course, we cannot invest money. We cannot really do what the industry can do, but I think we can provide a sort of proof of change, not a proof of concept, but a proof of change, how academia can push the development towards a more fairer distribution of production capacities. So in fact, we have a memorandum of understanding with Rwanda that was just signed, just as an example of how I think academia could contribute to reducing the inequities that we're discussing today. I don't want to go into detail about this because time is running out, but I should say that of course there are lights in the tunnel. There are many lights in the tunnel, and I think we see positive steps forward during this pandemic. But we have to exploit the momentum that we have now during this pandemic. There is time to act now, because soon this pandemic, I'm sorry to say, will be forgotten and we are back more or less to the sad normal. So we have to push this development and see to it that we can remove what is the most fundamental inequity, I guess, that has been revealed during this particular pandemic. And we have just submitted a paper on this, as you can see the title down below, where we suggest concrete measures to tackle some of these inequities when it comes to the technology divide. So these were my 14 minutes exactly, and I thank you for your attention, and I look forward to an interesting discussion. Thank you.
Professor Alderson, thank you very much for a really inspiring introduction to some of the key challenges, but also opportunities for doing better about improving patient access to healthcare across all our communities. I'm now going to hand over to the editor of the HPT journal, Professor Ken Reddecup, to introduce our next speaker. Over to you, Ken.
Thank you, Donald. The second speaker is somebody I know already, but it's my great pleasure to introduce her in this context. Dr. Jacqueline Bovy is Technical Director at NICE, National Institute for Health and Clinical Excellence in the UK. If you might have heard that before, the NICE, but she's had a variety of different functions at that organization, I think, and some of them include leading projects such as the European Data Evidence Networks and the use of patient preferences studies in health technology assessment. I think different growing areas that require a lot of knowledge, but also vision, I think. And I think that she's probably been a very good asset in that sense. Her training is in health economics. So she took her PhD in Utrecht, just up the road from here. But moreover, she was a colleague and student of mine here at Erasmus University. So it's please take it away, Jacqueline.
Thanks so much, Ken, for that very kind introduction. So I want to say I haven't prepared any slides. I want to say a few things about the way that NICE tries to ensure that that equity and equal access and health inequalities are taken into account in the recommendation that it makes. And my specific focus for talking about that is in the context of health technology assessment and the way we make recommendations for drugs specifically, because that's my personal area of expertise. So for those of you less familiar with what NICE does, so NICE provides guidance for the NHS, and we make recommendations for new drugs that receive marketing approval for England and Wales, and we recommend whether or not they should be made available through the NHS to patients. And one of the ways in which NICE tries to ensure, or the NHS really tries to ensure, that there is fair access and equal access to technologies that are recommended by NICE, is that it is a legal requirement. So it's part of the NHS constitution that when NICE has recommended a technology for use in the NHS through the technology appraisals program, it has to be made available to patients when if their clinician thinks it is suitable treatment for them. So that is a way in which we try to avoid something that happened before NICE was established more than 20 years ago. It was referred to as a postcode lottery, where there was a lot of regional variation in access, often to new and expensive interventions, where it could be decided by local budget holders whether or not new treatments and interventions would be made available. So one of the ways in which the system tries to prevent that from happening is that there actually is a legal requirement. So if NICE assesses that a drug is clinically and cost effective and should be made available, then patients have a legal right to treatment with that drug if it is prescribed to them by their physician. Of course, that's not a perfect system. There still are existing health inequalities in England and Wales, and I think the COVID pandemic has made that very, very apparent. So one of the ways NICE already considered equalities as part of its guidance. So it would always consult on whether, for any piece of guidance that NICE develops, whether there are specific equalities considerations due to the nature of the condition under review or the specific technology. However, we have recognized as an organization that this is it is a big priority for us, and we are actively considering how we can take better account of recognizing the impact that some recommendations and some guidance that we produce might have on hopefully reducing inequalities. But there are cases in which guidance and recommendations could potentially improve health for some groups in the population, but make outcomes worse for others. And how we should take that into account in our recommendations and our guidance is something that we're very much actively actively considering. I am going to stop there. That's kind of my my intro to the topic and my personal interest for it, and I'll hand it back to the moderators.
So, like I said, to me, it's me talking again now, but only to introduce the third speaker, who is Dr. Isana Hamuchi, who's a rheumatologist at Tanar's Hospital in Rabat, Morocco, and associate professor at the laboratory associate professor at laboratories of biostatistics, bioepidemiology, and clinical research, Mohammed V University Rabat. And she's also a founding member of the epiroom.com, which I think I can explain in a moment. I think that what she's her training, and she took a PhD in clinical epidemiology, and what you'll see is that she's combined that love for clinical epidemiology with her knowledge of rheumatology to spread the word. I think she's very active when it comes to education and also videos. And before, I should thank Jacqueline for the presentation, your words. I'm sorry, I forgot. I'd like to ask questions later, but I'll now give the floor to Isana.
Thank you for your presentation, and thank you for inviting me to participate in this webinar. I will try to share my screen. If it works, yeah.
Yep.
Perfect. So in 2019, the 4R group, consisting of 19 rheumatologists from the Arab League Association for Rheumatology, was formed with the mission to improve patients' awareness about chronic rheumatic disease. But since the beginning of the COVID-19 pandemic, the group has spread awareness to Arab patients throughout its vast network of social media and connection with the patient association. However, the impact of the COVID-19 pandemic on patients remains poorly understood. So in this regard, we conduct the handling study, which is the acronym of how are the rheumatologist patients dealing with the COVID-19 pandemic in the Arab country. The aim of this study was to evaluate the difficulty faced by the rheumatology patients in the Arab country during the COVID-19 pandemic. So it was designed as a web-based cross-sectional survey, which was disseminated online through social media and patient association. Between May, it was in the first year of the pandemic, and 2 weeks long. The survey consists of 15 close-ended questions and cover 5 areas, which is demographics, characteristic, impact of COVID-19 on rheumatic disease management, direct impact of COVID-19 on the patients, attitude toward telemedicine, and source of information about COVID-19. And it was disseminated in 3 languages, Arabic, English, and French. So this is the flow chart of the study. The link to the survey was clicked more than 3,000 times, and a total of 2,163 responses were analyzed. According to the demographic characteristic, the mean age of participants was 14, 72% were female, and around half of the participants were unemployed. 34% were from the Levant, 31 from the Gulf region, and 13 from North Africa. And there was no difference between age and gender across the region. In regard with the impact of COVID-19 on rheumatic disease management, as you can see in this graph, we have different colors which correspond of each region. The first one is the Levant region, the blue one is the Gulf, the yellow is the North Africa, and the green is all the participants. So in this graph, we could see that the COVID-19 pandemic had a significant negative impact on rheumatology visits, and this impact was less in the Levant region, and in Gulf we have more remote visits than the other region. And when we performed a multivariable analysis of the factor associated with the negative impact of this COVID-19 pandemic on the patient's visit to the rheumatologist, we found that female had a higher negative impact. The regions is different. There is highest impact on the Gulf and North Africa and lowest in the Levant. There is also medication non-persistency, acceptance of teleconsultation, and negative impacts on mental health remained associated with these rheumatology visits. Also, we found that 15% of patients with rheumatic disease stopped some of their chronic medication due to drug storage, and this percentage was higher in North Africa. In terms of the mental health, we found that almost 70% had some impact on mental health, more in North Africa, which you could see here in yellow. And this impact on mental health were associated with the impact on income. And as we could predispose, this impact was less in the Gulf region. When asked the patients about their attitude toward telemedicine, we found that almost all of them accept this teleconsultation with internet or with phone, dependent on the region and the accessibility of the technology. Also, to get information about COVID-19, the patients rely mostly on social media, and it's the same case for all regions, followed by television, then health practitioner, friends and family, newspaper, and radio. So in our study, we found that the pandemic negatively influenced, as we call the prospect, access to rheumatology care by affecting the visit to the rheumatologist and medication persistency. It also had a significant negative influence on mental health and income. The concern about the access to rheumatology care, to medication, and to proper education about drug persistency are most probably exaggerated because of the pandemic, but it exists. And there was this negative impact was different according to the region. So we suggest in our group, under the ARLAR, so the Arab League of Rheumatic Disease, different action to raise this disparity, which could be resumed as need for a reliable telemedicine platform to maintain the continuity of care for patients with chronic rheumatic disease. Medication persistency should also be strongly recommended by raising awareness among patients and also stakeholders, such as governments, who should work to avoid drug storage. Also, the issue of the mental health impact should not be neglected. And finally, at last but not least, all communication channels should be used to disseminate general guidance to patients, in particular social media. Nevertheless, effort should be made to raise public awareness about information authenticity and to avoid fake news. So this is what I want to share about our study, and I will be really happy to take your question.
Dr. Mamouchi, thank you very much indeed. Look forward to your contribution to the panel shortly. For our final speaker, we're going to turn now to Dr. Bettina Rühl, who has many perspectives on these issues. She trained in medicine in Berlin, PhD in London. She's a biomedical scientist based, speaking to us now from Uppsala. But she also is in a very strong position to consider how policymakers could be influenced by what realities are, including her perspectives as a cancer mission board on the European Commission, as well as her role in working group chairing for the European Medical Oncology Society as a patient advocate. So I look forward to hearing what your perspectives are, Bettina, on barriers to patient access and what is practical in how to improve them, and in particular, how you influence policymakers to try to make change. Over to you, Bettina.
Thanks so much for that kind introduction, and I'm very pleased to be here today to share a little bit a few, well, perspectives from different hats, as you have already heard. So personally, I ended up in patient advocacy because one of the driving forces that at the time I found unacceptable was that when my husband was diagnosed with metastatic melanoma out of nowhere in 2011, and we started looking for information, I had access to many more resources because I was working at the university here in Uppsala and I was medically trained. I had access to knowledge that allowed us to make decisions that were far-reaching and that I could see that others were not able to make. And while it did not save him, it definitely bought us time. And there was something unjust in that situation that you look back at your own life and you think about how close I could have been to have studied something else, and that would have meant so many different things, and it just didn't seem right. And I have built a European patient network system since then that works in, well, different countries. And our first focus was Europe, but we had then contact, for example, with patients from Lebanon, from North Africa, from Ukraine. And these situations look very, very different again. And what shook me was that within Europe is such a small space if you just look geographically, but it is a few hundred kilometers, usually west or eastwards or north or south, that made a difference in melanoma, whether you lived or you died. We were definitely a specific case. When my husband was diagnosed, 5-year survival was at 5%. We are now about 50% in the same time frame. So we've seen rapid progress, and you could really see the differences in survivals being split at country boundaries. And as you have already heard, I'm German. I studied 2 years. I spent 2 years of my medical training in France. Then I lived in the UK. Now I live in Sweden. So I'm definitely, I feel European, and that's something that, as a European citizen, I felt unacceptable. And this is how I got involved in different activities at European level, and finally also ended up on the Cancer Mission Board, where I have been predominantly working on the recommendation for personalized medicine. So what I found fascinating in terms of, and that has already been mentioned by different parties before, was that the concept of personalization of medicine is that what we are aiming to do is optimizing outcomes for the individual. And by doing so, we also optimize outcomes for society, because we're obviously reducing the waste, because also patients who do not benefit from our treatments will incur cost and side effects and negative outcomes. So I think that is as a concept, an important step forwards where we should be going. Obviously, the Cancer Mission has been affected by COVID, like all of us. And I would like to reflect a little bit on what I have felt was a change in the way the discussion occurred and how certain concepts actually changed. Equity and equity across Europe was one of the first topics from the starting point of the Cancer Mission, and it has always been there. But the way the discussion was conducted changed very much as soon as COVID came. And I mean, I think we all remember that our countries closed the borders and then hell broke loose. And we realized that we have to work together in order to maintain at least a minimal of functioning of our societies. We're still struggling with different cultures between countries, different handling. If you've tried to travel recently, you know that we can't even get that sorted on a European level. And you think you're actually meeting different diseases, though it is the same virus everywhere. But I think there's room for improvement. But nevertheless, there has been the realization that we as a space, we're geographically so tight, we're linked, we're connected, we depend on each other. That has been, if you have ever read the first contracts that will build the cornerstones of the European Union after World War II, there was a deliberate decision to interlink our economies to create mutual dependencies that will basically prevent us from killing each other, which I, as a German and having lost a lot of family in World War II, I think it's something that I'm very passionate about. That will hopefully keep us safe. And with this interlinkage and dependency, we now realize that health was always excluded. And I can tell you, when I started in patient advocacy, as soon as you came to the European health level and said, it is unacceptable that we have this inequality across Europe, the answer was always, that's member states' business. That has changed. I don't know whether who of you has listened to the Becker Interparliamentary Committee webinar just yesterday. The tone has changed. There is that realization that we as Europe have to act together. So there's definitely a willingness, and there is now also the willingness to put money on the table to actually act upon it. And I think for us as Europe, that is a very, very big chance. It's an opportunity to build something that will hopefully do something about inequalities in Europe. And I would like to pick up a few things that I believe are critical in this discussion. So first, what I thought, and I fully agree with the first speaker today, is that in the end, it comes down to governance and policy. None of us can do this alone. And that's why I find so attractive about the mission-based approach. And because I've studied on the cancer mission, but we have, for example, the OECD with a working group on mission-based anticipatory governance that is hopefully preparing our governments for a better, for being better prepared for the next catastrophe that is bound to come. In the end, I do not share the optimism that it is academia who's going to solve us alone. I do believe that this will require a broad involvement of all parties and societies. We all have a role to play. We are part of these societies. And if there's one thing, and we have heard this before, we have always considered health as a cost. I think COVID has taught us that the health of our societies, is an asset to our societies. Healthy societies will do better. So we should take care that health ends up on the asset side and not just solely on the cost side. As a patient, that's something that is, of course, very important, because the moment you get a diagnosis in amine cancer, I can reassure you, you go from a valid member of society, a tax-paying member, to someone who's considered a burden and a cost factor. And I sometimes feel rather like a parasite. And I don't think that this is rather adequate. It is not constructive, and something that I think we have learned now. COVID has affected us all. Cancer, 1 in 3 out of us will have a cancer diagnosis, and 1 of 5 is going to die. We all get older, so the problem is going to get more severe. A few more things that on there. So when it comes to equality, I think it is important that one thinks of it as a multi-layered and a multi-dimensional problem. We will always find someone who does worse than you. I've learned this in a European network, and my first conferences were that someone said, let's say in the UK, we have a problem with this. And then someone would come from Serbia and would say, yeah, but at least you have that. And with this, the entire situation comes to a pat and is totally unconstructive. This is not how we can consider and should talk about inequalities. Also, we are citizens in our own societies. We cannot push these policies against the will of our citizens, who in the end are the taxpayers and the members of our societies. So I think inequalities have to be addressed at any level within our own societies, within our regions, within our larger geographic context, and then globally. We have to do justice by all of them. And just because someone else somewhere is doing worse than you will not be sufficient to convince citizens at home. Something I fear is that universal healthcare is something that we all share. I think that's something that we as Europeans are rightfully passionate about. That is something that unifies us as opposed to many other places in this world. When it then, however, comes to the discussion, I feel there is this tendency to go for the lowest common denominator. So as in kind of, if some can't, if not everyone can have it, no one shall have it. And that is something I would warn against, because today we have already heard about the importance of social media. Patients are informed, patients have contact. And what actually happens is, if the state fails to provide the care that citizens consider as appropriate, they will look for alternatives. And that actually what it does is it increases inequality, because it is those who have the financial means, who are educated, who can read international news, who will be able to provide the second safety net for themselves and their families. So we actually aggravate the problem instead of solving it. And that's something I would warn against. The technical divide, I don't see as so strong between, I think we have to be a bit careful where the technical disruption will come from. If you look at financing, Africa is very much ahead. If we look at microfinancing, look at India. I've been on a course on social entrepreneurship where an Indian colleague set up a system, an app-based system where you could talk to a GP within, I think, 2 minutes. Try to do that in any of our countries. In 2 minutes, you're even not through, the answer phone. So I'm not sure from which party or which side the disruption is going to come. And I think we, especially in the Western countries, should be very careful, because I don't think it will come towards us and it will not come from us. Same is true for Central and Eastern Europe. where we already see alternative models to healthcare that to us might seem shocking because they upset our thinking, our traditions, the way we grow up, but I think it's a space to watch out for. Social enterprise for me has an interesting, like any type of businesses, and social responsibility is something that I believe we have to emphasize more. We have to take businesses are part of our societies, and we have to take them into the responsibility that they contribute to what we have heard, sustainability and health. And with that, I would already like to thank you for your attention. Thanks for the opportunity here. I think we live in interesting times. We are in a moment of shift. We should use the opportunity, as the previous speaker said, before we go back to normality and everything kind of fossilizes again. Thank you.
So Dr. Ruhl, Bettina, thank you very much indeed. So far we've heard some really important perspectives on a global level, regional level. We've heard about the potential role of regulators such as NICE or bodies to help advise best practice and how to either make that legally enforceable or not. And we've also had some key examples from rheumatology, but also cancer in terms of specific disease areas where there are challenges in what can be done and how can patients make an impact. Perhaps, Dwayne, would you mind, can you put up the poll question just before we go into the Q&A panel? We just got a very simple single question for our audience. Just take a few seconds to answer this. And clearly this is a very short list, but if you could just pick what you see as the current largest barrier of these options to accessing healthcare, wherever you are: COVID-19, cost of treatment, lack of the mobile health kind of tools that might support us, bureaucracy, inability to access the transport mobility to the services, long delays even if you get an appointment, or therapies not being available in your own region, country. So if you pick one of these, and we'll come on to that in a moment. So it's clearly a rather artificial way to look at this, but you can see we have a whole range of worries, concerns amongst our panel. And COVID-19 is not by no means the largest, which is interesting, I think. Cost clearly plays a large role in the list here, and clearly access. But there are many issues that people are saying. If you can move on now to a panel discussion, and I'd encourage the audience with a Q&A, do use the Q&A to raise any questions you want to raise yourself, or we may come on to you to address those directly. Perhaps I could start with you, Bettina. The right view is that patients should be at the center, patients should be involved. And there's been a tradition of, you might say, a token view of that, having patients introduced to ethical committees who are there, often, I think, in a passive role. But I just wonder, and the UK has been trying to push, as an example, clinical commissioning groups with patients at the center, closer to patients by getting GPs leading rather than hospital doctors. So that's one approach. I just wonder what your perspective has been, going back to the commission, as to what extent the commission is listening to you as a patient, as opposed to having you there as something that sounds good. To what extent do you see progress happening through patients being involved in that way?
Well, I mean, obviously I'm sitting on a cancer mission board, and not that was without trouble to get there, but that's a different topic. I think everyone realizes one of the criticisms when the mission actually started was that the citizens do not see the value of research and innovation for Europe, and did not feel involved. And I think that's something, especially now after COVID, I'm sorry that we always go back to COVID, but I think this has demonstrated beyond doubt that an anti-science tendency in our societies is dangerous for all of us. So if people do not understand how science works, how you reason, you already fall into really, really stupid traps, like logic traps, which we should avoid at all costs. So I think there has been a realization, and there have been public consultation and processes and interaction throughout the entire drafting of the mission. So there have been efforts, but to be honest, I don't think it's quite so easy and quite so straightforward. It's an easy talk, but it's not quite so easy to realize as anyone who's ever really tried to do it. So you will always find a patient. You can always cherry pick someone who will corroborate what you want to claim. That's usually how it is done. So you have a certain opinion, and then you ask someone who has an emotional story to support your point, and then you say, we have the patient in the room. And that's, of course, not what it is. I think it is quite interesting what we have now in terms of discussions about the digital health data space and the GDPR, because that actually gives the patient, as the one who owns the data, a role that it never had before. And now lots of other stakeholders are waking up that they actually have to ask for permission before they can use with the data whatever they like to do. You can hear from the discussions how upsetting many find that, because they're not used to actually have to ask for permission. And I think it has already created an interesting debate. For example, also if we look about digital tools that depend on patients using, for example, an app. Because we shift the decision to the end user, all of a sudden patients can tell us what they want. And I think that is the way to go, to have a very long answer to a short question. I believe we have to get more honest, just letting people decide in front of a decision. If you just ask a person, what do you want? And I've been trying this as an advocate because I have exactly the same problem. What do you want? You often don't get a really helpful answer. So what we've been starting to do is we just test and see how people decide. We even did a research project with the EMA on risk benefit preferences on the same problem. And I think we all have to get better to watch and measure what actually happens and what people need in that specific situation. At the moment, there's a little bit too much thinking that this could be bad, good, and projection. And I include myself because as an advocate, one always is at risk of doing that. So I think that is where I see where it will go, and digital will help, and we're definitely moving towards that also in the Beating Cancer Plan and the Cancer Mission.
Thank you very much. Can I turn now to Professor Otterson? And I'm picking up a question from the Q&A, which is relevant to your talk. I won't go into all the detail, but Hiren Thanki makes a note about clinicians, academics, public health bodies, professional bodies arguing for better access, more investment, and so on. However, politicians don't necessarily support this. There's all sorts of reasons come up. Just to give a very brief example, we had a commission in the UK for pandemic preparedness, and it concluded 4 years ago, that's to say 2 years before the pandemic, that it should be very expensive to stock equipment, they might go out of date, and so on and so on. And so all sorts of excuses not to do things. So the question from Hiren Thanki is, how is it possible to make political institutions really accountable, given, say, they're voted in once every 4 years? Once they're in, then it becomes quite difficult. How do you see, Professor Otterson, ways to make the political organizations listen and respond more quickly than has been historically the case?
Well, this question is spot on, and this is key to our understanding why we have ended up in such a dismal situation as we are in today. Because, you know, when it comes to vaccine distribution during a crisis, it's certainly within the time horizon of a politician. But if you're talking about building production facilities, which is of course the only sustainable solution, you are far beyond the time perspective of an average politician, with due respect. So this is the key issue. How should you ensure that what we do today has the appropriate time perspective that is needed to build what I coin sustainable health? There is no easy answer to this, but Bettina says, if I understood her correctly, Bettina, if I understood you correctly, that academia alone cannot do the thing, and I completely agree. It must be in collaboration with others. But the point is, and this is so important, academia by nature has a longer time perspective than the average politician. That's why our role is so important. The task of a university is to compress time. So we see the relevance of past history, but that we also see the relevance and engage with future generations. Compress time, that's the issue. That's the task of a university and academia. That's why we have to engage much, much more energetically in these issues.
Thank you very much for that. Just as an interesting historical comment, I wasn't aware of this until recently, but George W. Bush gave a speech to NIH, I think 2005, in which he requested a small number of billions, that's so in a huge budget in the US, for 3 categories. And this was in the context of infection pandemic. And my recollection is that 3 categories he thought were really important were to have more stockpiles availability of PPE, simple equipment, low cost equipment, but available. Secondly, to have much more infrastructure, so you have the capacity to produce more research investment, so you're ready to have the trained academics. This is the long view. But the third thing, which I think is really important and a real for academics as well as others, is how do you educate the public to be aware of what they should be interested in, and to be, I suppose there's two things: not distracted by fake news, or more capable of understanding the difference between random stories and evidence base, and within that really understanding risk. So you have a medicine, there's a risk, you may want this expensive medicine, but it's not always in the best interest. So that, I thought, very interesting long-term perspective from somebody who perhaps hasn't got the tradition of that recognition. Can I turn now to, I can ask the panel, if there are questions you want to ask the others, please use the raise the hand symbol. But meantime, if I go back to you, Jacqueline, you mentioned the issue about NICE having its authoritative statements, but also having the legislative mark that whatever you agree has somehow to be delivered. Now, there's big challenges there. Now, I just wonder, the two things: NICE guidelines themselves imply that there's an option, they're pure guidance, and yet you have this push. I wondered to what extent you can say something about the UK and how UK is trying to make sure guidelines are actually implemented, and also beyond that, to what extent you say something about NICE and its influence well beyond UK boundaries.
Thank you. Yeah, no, it's a good point, and it is. So clinical guidelines obviously take a much wider view. So the funding mandate applies specifically for technology appraisals. So that means that it's recommendations mostly for drugs. So if there's a recommendation from NICE for new drugs, then that funding mandate applies. Clinical guidelines, of course, are guidelines, so they are not mandatory. NICE does have an adoption and impact team that does work to ensure that there are tools available for the implementation of clinical guidelines, because of course they're not mandatory, but they are a summary of the best evidence available about what technologies and what treatments should be made available to people in the NHS. So there are ways in which we try to help the system to implement those types of recommendations. And I think you asked the second part of your question that I'm not sure I remember.
To say something about NICE, and I suppose your collaboration across frontiers, but also the influence that NICE has in terms of its guidelines being adopted or maybe fine-tuned, but taken seriously elsewhere in the world.
Yeah, so I think that NICE is in a very privileged position, and that the work that we do is well known, and I think recognized by others that there's some value to some of the approaches that we take. We actually have a program called NICE International, in which we work with organizations and healthcare systems and governments around the world, actually, to, if they have questions or are interested in some of the methodology or systems that NICE uses, such that we can do some of that knowledge transfer and work with other healthcare systems to help them improve create systems that have some similarity to the way that NICE does its work.
Thank you very much, Jacqueline. Ken, can I just turn to you? Your background is health economics, it's health technology assessment, and it's not your direct area, but I just wondered to what extent you can comment on, there's a whole range of smaller patient groups who've got difficulty accessing the research to get the drugs available, the diagnostics available, and then beyond that, the clinical trials. And big data is certainly something which has become an option. It's maybe dirty data, but it may be very helpful. Can you say something a bit about big data and how that can perhaps help improving patient access to the health system in the first place and treatments? Ken?
I guess one of the recurring issues is whether or not we should be using the same methodology when we look at big data. I think ultimately the assessment criteria we use presumably should be the same, whatever intervention we're discussing. Interestingly, we can talk about all the potential when it comes to health gain. So in other words, we're thinking about the improvement in effectiveness that big data and big data analytics and AI and whatever can achieve for us. If we have that data, we can reach the moon. We tend to ignore the impact that big data and big data analytics can have on equity, right? So some people can go up in the sky like an astronaut, or perhaps in the very near future go to the moon, while other people will be living without water and proper sanitation, right? And we don't talk about that. right? And that raises some issues about who's going to be financing these things. But I think we tend to think about the impact that big data will have on effectiveness, and rarely we talk about the big data, the potential impact, positive or negative, that it could have on equity. I think maybe I would ask like one of the panel members to whether or not it has any resonance, or whether you think maybe there's another opinion. Anyone?
I'd be happy to respond to that. I think there's a lot of interest, and NICE has an interest in the use of big data, real world evidence, that type of thing. But there are, and I think I read something the other day about Apple looking at developing measurements of cognitive decline, I think, or measuring cognitive function. And you can imagine that the amount of data that it actually has available and the potential ways in which it could very sensitively measure that just in how you interact with your phone or with your laptop is potentially massively valuable, and way more valuable than some of the clinical assessments that we have available and that we rely on for diagnosis today. But at the same time, there also are limitations to where the data is, and whether it lives on your phone or whether it's in a wearable, whether it's in electronic health records. Linking all of that information up, I think we're still a big way out from making that a reality, where all of these different, the information is all there, but it's very disconnected. And even within electronic health records, there also is information in there that doesn't necessarily get, if it's not measured, stuff that's in an electronic health record at the moment is measured for healthcare delivery. So if you want to use the data for secondary purposes, that doesn't necessarily mean that if it's not information that's essential for healthcare delivery, it might not be in the system because there's no point in measuring it. So there still is a lot of work, I think, that needs to happen. There's a lot of potential, but realizing it and it becoming commonplace, I think we're still a bit of a way off.
Thank you, Jacqueline. Ihsan, I was interested in the survey you had. Clearly, it's a sample. The question is how systematic, how biased there might be. Nonetheless, what you did seem to show was remarkable acceptance of the idea of not seeing your physician, your healthcare professional face to face, whether it's by telephone or in some other way. And as a question for you, I just wondered to what extent your survey, noting key issues, key ways to improve your specialties reach for patients, rheumatology, how that works, say in Morocco directly, to what extent you can then take that information to your health authorities. Do they listen? And then also you mentioned Levant and Gulf and North Africa. To what extent, we heard from Bettina about European cooperation or best ways to try to work together. Is there a good political view about cooperating across the regions when it comes to health?
So I will respond to the first question. So that's what the issue of our survey. After the end of the study, we collect a task force about recommendation in telemedicine in rheumatology. So we work on a recommendation which could be applicable in our context and with our different particularity. And the manuscript is under submission, and it will really interactive, interesting session, because we heard from each other. We have different policy, different insurance, different GPD, but the same patients in really ways. And we see that finally, especially in rheumatology, there isn't really a major imports. The most disability could be challenged by prevention, by good communication, but by good hygiene, and by some medication, which is not really cost effectiveness. So for this topic, we focus on telemedicine and telehealth in this particular patients, and we see that we could monitoring this health. And because when we speak about big data, I have one friend of me which is a professor of intelligence artificially, and she always tell me that the big data shows us as we are. So they shows our inequality, they shows our disparity, they shows what you put on the machine, we will find it. So we need to have a country's health information system, and to begin to collect all this data to get analyzed, and also the qualitative data, not only the quantitative one. So after this study, we begin the recommendation on telemedicine, and we will, in order to begin the implementation of it in different country and in different center, to see how it will be applicable and efficient for our patients. This is the first thing. And the second thing, it's about the different region and the difference across Levant and Gulf and North Africa. We have really different policy and regulation across this country. We are Moroccan, and in North Africa, we are really near Europe and European countries, so usually we follow the regulation of the European country. However, in the other hand, like in Gulf, which they have high income and more equity, they maybe follow from ASER, the American country, and assurance, and it's make a gap between our prise en charge for each patient.
Thank you very much, Isan. We've got a couple more questions from our audience, if I just pick up on them. Maybe staying with you, Isan, there's a question here about what about using herbal medicines? I know that the EMA has been focusing on the science of herbal medicines, but certainly in Africa, folk medicine is very widespread, and with low numbers of formal healthcare professionals, there's certainly an issue about is there some way you can scientifically use the health folk doctor network? Is that something that's practical? When I worked in Rwanda, there was a background story there that the WHO was interested in regulating, but hadn't quite got the resources to work out how to do it. I just wonder whether, say, in North Africa, there's something which might be happening.
There is some,
can you unmute?
There is some pilot study on herbal medicine in rheumatology, particularly in osteoporosis, with penicillin colocum and other. But actually, we are not doing it regularly, and it's not in our routine care. So maybe in the future, but there isn't enough research and funding to do research and to get proof and fact to do it in evidence-based medicine way.
Thank you very much. The other question is from Sylvia. So she's just making a very practical comment. GPs are busy. Patients who do get to see them feel that they don't want to trouble the GP, therefore they don't perhaps make the most of a system. And the question is, how on earth do you, it's about capacity really, how do you find some way to make those contacts as effective as possible? That's really, does anyone want to pick up on that? I mean, it's a fact of life really. People go in with 10 questions, the GP's got time to answer one question or two people.
Can I add an additional thought to that? I mean, one option that many people we immediately think of is telehealth, right? COVID sort of demonstrated that there's an opportunity to receive the information you want from a distance, or like in the comfort of your own home, or with the comfort of your own smartphone, right? How does the use of the access to telehealth relate to improving or reducing equity? So what's the relationship between telehealth and equity? I mean, you can use this solution, right? That's definitely one way to make the system more efficient, but will it make it more equitable, or create better equity?
Maybe to build on that. So 2 points. Actually, I think a lot helps already if you can ask, and this is something that we do a lot in oncology, is basically to tell people before what to list. So that basically a written down record of what your needs are and also your questions, that usually helps to structure an interaction and get you also to remember especially if you get bad news, you go into like, it's very often that you just tend to forget what you have been told. And it's like as if this consultation had never happened. So I think there are tools that can help to already prevent some of that kind of lost in translation, if you like. Many of us in oncology have been excited by a presentation from ASCO 2018 in the plenary where Ethan Marsh and colleagues, and that is actually building on a French study earlier on, like he presented a year earlier, that didn't get the attention, but basically showed that you can use a simple app like a PRO reporting tool, EQ5D, for anyone in the field that is as coarse as it gets, but it was sufficient to pick up a deterioration of quality of life. And if that then led to a trigger, so to call in patients earlier than anticipated, they were able to show that it led to an improvement in overall survival without any new drugs, anything else. So I think the difficulty in there is that everyone talks about the app and how great it is to let patients report. What people don't report or talk about is how difficult the implementation is, because it basically changes the way that we deliver care, because it is now based on a trigger instead of we call them in every 3 months. So I think it is something that we can do on the delivery side of health that can help to match this kind of demand that we're currently not having. A topic on telemedicine, because that's always the comment, will it increase inequality? Something that I thought was quite interesting, what our people reported, so because everything went on to telemedicine, that people felt that the communication with the medical team was more equal, because everyone was on the screen and they actually appreciated that the conversation was more on equal terms, and they felt that they were better able to articulate what their needs were. That was one point. They also found it more respectful towards their time, because you get a slot in, it's 2 o'clock and they will be there at 2 o'clock. While lots of our people waste entire days at hospitals waiting for overrunning consultations. So people commented on the equality of the interaction and the respect for their times and noted that as positive. And that's something that I hadn't crossed my mind, but it comes up again and again and in different countries on different forums. So, I think it's not just always going towards the negative side, but maybe we can keep some of the learnings also on the positive side.
Thank you very much. I've got one further question for Professor Otterson. Then after that, perhaps we could go around the panel and ask each of you just to pick up at any key points you might want to ask the others before we close. Professor Otterson, you mentioned the idea of collaboration with other countries, and particularly the Macquarie agreement you have. I just wondered what you see as practical outcomes of that collaboration.
Yeah, first I would like to, if I may, comment on telemedicine, because I think I refer to the technology divide. And I think Ken's question is very, very, very important and timely. And that is that cell phones can bridge the technology divide in the world. And we are seeing now, not least when it comes to maternal health, the power that telemedicine has. We can reach mothers, pregnant women in all parts of the world, essentially, to help ensure that they get the healthcare that they need. So I think this is a fantastic possibility ahead of us to really exploit telemedicine in full, because as also Bettina points out, here, all of a sudden, we can see that even low and middle income countries, they jump to cell phones and can use them creatively in their healthcare. And we are seeing also in Sweden and in other countries in the Western world that telemedicine has a tremendous potential, but we should use this potential wisely so that they don't really increase inequities, but reduce them. And there's certainly potential for this. When it comes to
just to touch on that very briefly, I think you're right. The question is how best to use it, but as a wonderful example of what could be done, and this really raises the question: how do you get the people, the public, to engage effectively in their best interest, but to help other people? Tim Spector, who's based at St Thomas's in London, who made his name on a very big twin study, he launched an app where he said several million people, I think it's 3 or 4 million people in the UK, who virtually every day will say, I am fine, or I have this symptom, or something else is coming. It's very COVID motivated, but it's a way you can capture a huge amount of data with the goodwill of people out there and the noise in there. It gives you an example how with a particular big challenge, you can get a very large minority of the population can engage those who've got access to the system. Anyway, I interrupted you. Back to your...
Yeah. So the other question had to do with the Macquarie project. And I think this is hopefully moving straight into what is the key issue for this debate. And that is to ensure that we build capacity, and capacity that really can ensure that the community, the local community, gets better access to healthcare. It's very much about, again, how to ensure that new knowledge is being translated into better healthcare, and that's why we need to have long-term projects. One example that came up in a discussion we had here just a few weeks ago is schistosomiasis, which is of course very prevalent in many African countries. And there are pretty good treatments for schistosomiasis. But in one of these investigations, researchers had found that I think it was almost 90% of those who were checked for schistosomiasis, in fact, had the disease. And despite the fact that treatment and even prevention was available, this tells us in no uncertain terms that one thing is to have knowledge, the other thing is to implement this knowledge. And then we need to have a sort of local community anchoring of the research project. So that's perhaps the most important thing with our Makerere project. We do invite local community engagement, not only invite local community engagement, we see it as essential for progress. And this speaks very much to what Bettina raises. I mean, we have to look at not only at the patients, but also at the needs, on the needs of potential patients, the community, local community at large. This has very much been ignored in many international collaborative projects within the realm of global health.
Thank you very much. Any final comments from you, Bettina?
I think something that I have been thinking about a lot also in the last year, when we had all those about the fake news and how we deal with this. And what I found pretty shocking was first the low level of discussion even within the scientific community. It went very fast onto very personal attacks, which I thought were below the standards of anyone with any scientific upbringing. I mean, you get usually taught in a journal club very early on in your scientific training how to behave and how to discuss, and people seem to have forgotten that. And then also this kind of revert, I mean, it was just like a regression from evidence-based to eminence-based, trust me, I'm the expert discussion, which I thought was pretty shocking. I hadn't expected that, to see that also, in the 21st century. The way we think about it is that what we need is something like, if you have distributed knowledge, which we have, if you look at the internet and the communication, it is distributed. What we also need is distributed control mechanisms. So there will not be the one and only who has the right opinion. It will be, how do we protect people, or how do we enable people to recognize true from false? And we have to be able to communicate complexity in a more appropriate way. I think the odd thing, odd is maybe not the right word, is, but when we saw that vaccinations didn't work quite the way we had hoped, all of a sudden the discussion became more respectful, more instructive, better quality. And I think that is something that we all have to take at heart. And I believe that anyone who's scientifically trained should be part of that. And it's not lecturing people, it's explaining the gray. There is not black and white, there's a lot of gray in science communication, and that takes time, unfortunately, to really explain. And I think that's the only way how we're going to keep our societies safe, and protect them from what we call fake news. I think that is something that will become more and more important the more we move towards digital, the more we go to distributed systems, the more participation we want from patients, the more it will become important that the individual is really able to make decisions in their own best interest and based on a system, not just someone telling them yes or no. So I think that would be my kind of, reflecting on the last 2 years and also our discussions today, because otherwise we will increase inequality even further between those who have understood how it works and those who fall for some empty promise.
Thank you very much, Bettina. Isen, any final comments from you?
The final comments will be on telemedicine and telehealth. I think that we need best practice guidelines, and we need to implement that best practice guidelines where we have it, just to facilitate the teleconsultation and to add credibility, standardized approach, decrease liability, and facilitate reimbursements. And with this kind of stuff, we could facilitate the implementation of this new device and new health services. Thank you.
Thank you. And Jacqueline, final thoughts from you?
I think just one thing to add is that I think that I think that most of us have very much a health and healthcare system focus, but the pandemic has made it very, very clear that something that has always been the case is that what happens outside of healthcare in society has an impact on health inequalities, and the decisions that we make within healthcare also impact people's life in many different ways. And I think that we have so within NICE, that is something that we're considering as well, that we don't, even though we make recommendations for the NHS, that there are wider implications of some of the stuff that we do, and that we might need to take note and take more consideration, because I completely agree that with what Professor Alderson said, ultimately it is about the entire system. It's not just within a healthcare system that we have the power to make these types of changes and improvements.
Thank you, Jacqueline. And Professor Alderson, the final word from you.
I will continue on Jacqueline's statement here, because she's absolutely right. And that is that health is, in essence, multi-sectoral. It goes far beyond the healthcare sector. That's why you have the political determinants for health. You have to look into the politics of each sector. I mean, just one paper that I just read serves as an example. It was a paper about what are the key interventions we need to have to improve adolescent health. I counted the interventions. 13 out of 15 interventions were outside of the healthcare sector. They had to do with nutrition, they had to do with education, they had to do with how we organize the cities, this kind of thing. And this is perhaps the most important take-home message, I think. So not only health is created outside of the healthcare sector, but inequities are created outside of the healthcare sector. That's why cross-sectoral thinking, system thinking is so extremely important. And I think this discussion has highlighted this particular point. To my dismay, I still remember, because I was a very young child at that time, when Martin Luther King gave his speech in Chicago, 1966, he said that of all the forms of inequality, injustice in healthcare is the most shocking and inhuman. That was in 1966. Had he lived today, he would have been utterly disappointed about the lack of progress.
Well, on that sobering point, well, thank you very much indeed, Professor Alderson, and thank you to all today's panel. If I could close by just handing back to Ken, just to say a very brief word about the next two sessions coming up, and then just a note about the journal. Over to you, Ken.
Yes, thanks, Arnold. This is the third in the series of webinars, which has been organized in light of the 10th year anniversary of the journal Health Policy Technology, as you can see on the right-hand side. So the next two that will be coming up are addressing geopolitical challenges to the price of medicine in a month from now, which is very much related to equity, of course, right? It's like the other side of the aspect, and we might have to get back to equity when we talk about prices. And the third one, which encompasses even more, is climate and health. Why should policymakers and the public be concerned? I think there we can talk about the interconnectedness and the fact that we should not be thinking about one ministry of another, and not just one country another, but the fact that everything is related to everything, so to speak. This webinar series relates to the journal and to the Fellowship of Postgraduate Medicine, but one of the sponsored journals, Health Policy Technology, which is an Elsevier journal, which is, as I say, 10 years old, which covers basically everything that's under the sun when it comes to the relationships between health policy and technology. And I think my own idea about how to fill it in is basically wherever technology is going, policy might follow. Let's think about what the policy implications will be and think accordingly. With that in mind, I think we have to be thinking about engaging everybody, including not just policymakers, but the public, to understanding what these technologies actually entail and where it could be heading, to sort of raise the discussion about what we should be doing in terms of not just what we purchase or whatever and what we reimburse, but rather what should go into law and what should go into policy making. I think, and otherwise we will just be reacting just like we did to the pandemic. I think with that in mind, I think the pandemic, I think that Professor Ottoson made a very good point when it came to the pandemic. It's a sort of a silver lining, you could say. It caused a lot of death and caused a lot of misery, but it's also an opportunity to learn, and we have to remember these things and write these things down and discuss them before we start forgetting the things that we all experienced collectively in the past year and a half. Thanks.
Thank you, Ken, and thank you once again to all our panel and to all our delegates for joining us today. Goodbye. I look forward to seeing you in a month's time.